Greetings everyone, and welcome to this briefing on a very important topic, dear to the hearts of all of us on this panel. And on my panel, of course, Winnie Byanyima, the Executive Director of UNAIDS, and Peter Sands, the Chief Executive of the Global Fund to fight TB, AIDS and malaria. Our subject today, of course, is HIV AIDS. We've recently been through a COVID pandemic, but before that, the pandemic uppermost in the minds of all of us on this panel was, and should continue to be, the AIDS pandemic. A pandemic which has taken 42 million or so lives. We have made huge progress in combating it, largely because of the ability to mobilise huge support and get access to antiretrovirals. That was a game changer in not the last decade but before, and made a difference, the difference between life and death for many. But nonetheless, as UNAIDS will tell us, the virus is still winning. When you have another 1.3 million or so infections a year, new infections, this is highly problematic. And the adolescent girl stands as one of the most endangered in this ongoing pandemic. Now, there are huge opportunities out there for a breakthrough in how we approach and overcome AIDS, how we achieve the end of AIDS as a public health threat. And that is what we're here to be briefed on by these two extremely well-informed and passionate advocates today. We need this breakthrough in a world which is fractured, in a world which saw such huge inequity between global health and South during the COVID pandemic in terms of who had access to what and on what terms. We must not let history keep repeating itself with these inequities. How do we do things better in this age of opportunity for breakthroughs, I think is our real question today. Winnie, perhaps starting with you first, we have remarkable new science with the long-acting drugs that could prevent new HIV infections with just 2 shots a year and keep people already living with HIV alive and well. But we know scientific breakthrough is one thing, we know access and affordability is another. So what needs to happen to transform this remarkable science into the end to the AIDS pandemic?
Thank you, Helen. It's wonderful to be here at this briefing with you and Peter. You know, every day, you just said, there are 3,500 people who are newly infected with this virus. 3,500 every day, 1.3 million every year. And by the end of today, 1,700 people will have died of AIDS-related illnesses. So the disease is here. But like you hear with us, 40 million people are living with HIV today around the world, mostly in Africa. 31 of them are on treatment on these amazing antiretrovirals. But 9 million we haven't reached, and 1.3 million are added every year. But this is great news that we now have something that can prevent just 1 shot every 6 months. But as we know, and you said it, that when new medicines, when new innovations reach us, hit the market, it can take up to 10 years before the medicines reach everybody who needs them. And we don't want that to happen this time. Lenacapavir and other, it's not the only one, and other medicines that can prevent people from new infections should get into the hands of girls and women in Africa who are the most at risk in the whole world, in Africa, to gay men, especially in Eastern Europe where infections are rising, in Latin America, in North Africa and the Middle East. We need to get it to them fast. And that means we have to push the companies to stop hiding behind their monopolies, the monopolistic rules, and move quickly to license companies in the low and middle income countries to make generics. We know that this amazing lenacapavir, for example, which is now costing $40,000 around that on the American market per person per year, if produced in large quantities, could come down to $40 per person per year. And that means all these girls who are pushed into forced sex, who for various reasons get infected, could have it. So we want to push the companies to license more companies to make cheap generics. And that means we need the governments on board, because these same governments have been amending their own laws since COVID to make sure that they can push companies to do the right thing when there's a health crisis. But they're doing this for themselves, for their own markets, not for the world. So we need to get governments cooperate, get the companies to move quickly. Lenacapavir is owned by Gilead, and I know that they are in discussions with our partners, the Global Fund and PEPFAR. And we are here to encourage them to move fast, to make this happen. There are countries, for example, that were involved in this, in the trials, countries in Latin America, that are not even included amongst the list, the 120 countries where they have allowed the product to be produced as a generic. They have left out people who were part of their trials. So we're here to push them to do this right. This is what we need. But of course, beyond getting the medicines at a lower price, there are other things that are preventing this from happening. There are very weak, broken health systems in the lower income countries of Africa. We need to get money into those systems to strengthen them. A pandemic cannot be managed in air. It needs a strong health system. We do need $9.5 billion gap in the response. And that we want that the donor countries remain, do not pull out, but remain engaged to fight and end this disease. We need all countries on board and putting their money into Global Fund, putting their money into PEPFAR. Those are the two big funds that support the low-income countries, middle-income countries to fight. So we need that solidarity to remain and to help those countries to tax and have money to fund their systems. Those are some of the things. And there are more, but I can come back later.
Thank you, Winnie. Peter, the Global Fund obviously has played an enormous role since the early 2000s in access and affordability and rollout. When I was at UNDP, we were pleased to be a partner in supporting that effort as well. But give us your perspective on where we're poised at the moment and how we can move forward.
Well, thanks, and it's great to be here, Helen, with you and Winnie. At what I think is a absolutely critical moment in the history of the fight against HIV/AIDS. As you said, the emergence of antiretroviral treatment was an extraordinary game changer. When you look back, it took too long to deploy it at scale. As Winnie said, it cost too much and it was too hard to give people access, and because of that, millions of people died. But since then, we now have expanded antiretroviral treatment enormously, and the cost of it has plummeted from when the Global Fund was created. It was something like $10,000 per person per year. Actually, now we're getting it for about $37 per person per year. Although, as Wendy noted, there are still 9 million people who are HIV positive who are not on treatment. So there is a gap there. So that was a game changer. And I think what we are seeing now with the emergence of lenacapavir, but also a range of PrEP and prevention tools, including the Diverapin vaginal ring, we've got another game changer on our hands. And it is incredibly timely because it gives us the opportunity to once again change the nature of the HIV pandemic, which is if we can significantly reduce the numbers of new infections, then yes, we still have 40 million people plus on antiretroviral treatment, but we're not constantly growing that number. And that is a hugely different situation to be dealing with. Now, the trick is going to be how quickly and how effectively can we get these tools to the people who need them most. Just before the Christmas break, we made an announcement alongside PEPFAR and the Children's Investment Fund and the Gates Foundation of a collective effort to bring lenacapavir to 2 million people within the next 3 years. And that roughly coincides with the period where we're expecting the supply of lenacapavir to be largely the Gilead branded product as opposed to the generic product, which is likely to follow sometime in the next 2 to 3 years, depending on how quickly the manufacturing is scaled up. And what we wanted to signal with that announcement was that we don't want to go small. We want to seize the opportunity, even before the generic product becomes available, to make a significant difference to the trajectory of the disease. And for those of you who sort of aren't HIV people, the PrEP has already been, oral PrEP has already been a very, very powerful intervention. And in many of the rich countries in the world, it has played a huge role in bringing down levels of new infections. The challenge for many of the communities most at risk in other parts of the world is that there is significant stigma and other obstacles to taking oral PrEP. And a 6-monthly injection, which is effectively 100% effective, is a way of bringing the power of PrEP to people for whom the oral PrEP solution doesn't really work that well. And in a way, the way to think about this is, and it's interesting because we talk about prophylactics very differently than we talk about vaccines, but from a patient perspective, lenacapavir is functionally equivalent to an almost 100% effective short-acting vaccine, right? It gives you very, very high levels of protection for 6 months. So to make this happen, we will be working with partners, including UNAIDS, with Gilead, with the generic manufacturers who have the licenses, to try and ensure that we can get accelerated and affordable access as quickly as possible. And that means in 25, this year. So that is where the ambition is. Now, the other thing that's going to be really important is that we don't just think of this as a kind of bolt-on to existing prevention efforts, that we seize the opportunity to really re-energize and rethink the programs that are happening, whether it's in schools or various different communities, whether sex worker communities or communities of men who have sex with men, to really rethink and re-energize those efforts. So what we are currently doing working with partners, working with communities on the ground, with national AIDS programs and so on, is looking at what are the best ways of using these tools and ensuring they get the right tool gets to the people who can benefit most. This is not going to be something where we can't afford, we won't be able to afford to, but it also won't be the right answer to sort of roll out lenacapavir to everywhere. Different people will want and need different things. And so there's a lot of work to be done on how to most effectively implement these interventions. But if we can get it right, if we can get the access affordable, and we can get the execution of the programs, the implementation of it effective, we have this kind of amazing opportunity to change the trajectory of HIV in a short period of time. And that's extraordinarily exciting.
Yeah, please come in. Very exciting points coming out of the conversation, and Winnie, you're going to come in on a point, but also, it's one thing to roll it out to a country, but then if there's stigma within a country against the sex workers, against the rainbow community, against the people who are injecting drugs, then you've got another built-in barrier at that level too. But please say what you were going to be prompted to say, Winnie.
Yeah, I'll come to that. I wanted to say that the ambition, we want to raise the ambition. We see that, we know the target that we have now is that we would want 10 million people to be on prevention, what we call PrEP. Yeah. So there are various types of PrEP. Lenacapavir is now the magical one, which is an injection every 6 months. Now, they're talking about 2 million people coming onto lenacapavir. That is the target. But we're saying if we are going to end this disease by 2030 as our goal, we need to get 10 million this year on treatment. So it's a question of speed and scale and the ambition for that. And we think it can happen. Look, when we had COVID, within a year, rich countries came together and found the vaccine. And when the vaccine was found, within the first year, 4.5 billion, not million people, had been vaccinated in 1 year. 4.5 billion. Yeah. Take also the case of injectable contraceptives. Every year, 72 million women and girls get that injection, the contraceptive. So it's not impossible. But you see that companies drag their feet in order to maximize on the original innovation, take their time to pass on the generic, to get it going, to get it in people's hands. So it's speed and scale, and we are pushing for high ambition here. Then I also mentioned the countries that are not included. Gilead has said 120 countries can have that generic, but Brazil, Peru, Mexico, Argentina, these are countries with, some of them, the new infections are increasing. In Peru, new infections are increasing by more than 80%. Venezuela, by 98% increase in new infections. But they are not part of those who will benefit from generics. So it's also about getting all those who need in low and middle income countries, being able to access a cheap generic and to get it quickly. So, but you're right, it's not just about the technology, it's about stigma. But that's the magic of this, because an injection is a really powerful way around stigma and discrimination. Think of a girl in Africa. She doesn't want to be swallowing a pill every day just in case she's going to be forced into sex. She doesn't know when that will happen. But she knows she's now in puberty, and Men around her, even in her own home, at school, are beginning to make advances at her. She gets this injection. She goes to the clinic twice a year, and she's safe. So it does, but if she was swallowing a pill, she'd look like, this is a loose girl. There would be stigma. There would be a sense that she's doing something wrong. So this is powerful. But again, we have to push back against stigma and discrimination. If you have gay men, I love the name you gave them, the rainbow community. People of the rainbow community, like those in my country, in hiding, because there's a horrible law, because there's strong stigma, they are attacked. They will not come for this magical lenacapavir. But in a way, it's better than a pill, because they go only once. Maybe now it's going to be once a year. But still, unless people enjoy all their rights, I'm so sorry.
It's hard to access. Yeah.
Access is impossible. So we still have to keep fighting on rights. And sadly, there's a pushback against human rights, against women's rights. And we must stand together and maintain the gains and push forward for rights, because health rights are human rights, and stigma is in the way of enjoying a health right.
Our panelists are describing the complexity of the issue, because it's so much more than the scientific breakthrough. It's then how and on what terms can you make that available to those who most need it. Anyone in the audience who would like to put a question to the panelists? I have plenty, but you've also done us the honour of coming. So would anyone like to offer a question? Yes?
Is there a stigma about them, or just not available, or not used? They are all effective. I mean, condoms are an effective barrier. Voluntary circumcision has reduced infection rates. But there is no single answer. And even though we are very excited about the potential of long-acting injectable PrEP, lenacapavir, it too isn't the single answer. Different prevention tools will be appropriate for different people in different communities. And it's a question, above all, of making sure that people are aware of what tools are available, have the access to the ones that fit their circumstances most. So it's not that we haven't got tools, it's just that the power of a long-acting PrEP is, particularly for those most at risk, is, as Winnie described very well, it overcomes a lot of the issues around stigma and adherence, where one of the issues with oral PrEP is that you have to keep taking it. And one of the issues with condoms is you actually have to use them. Women who are often most at risk are not always in the position to be able to enforce usage. So these new tools complement existing tools, but they do so in a way where, if we get it right, the sort of aggregate prevention impact will be very substantial.
Can I come back to the licensing issue? Because Peter's outlined the discussions broadly that are going on for the Global Fund. Winnie, you've referred to the 120 countries where Gilead's prepared to give licensing. But then there's those middle-income countries who are not in the picture. Now, to the extent that the WTO managed any reforms to the licensing system around 3 years ago, it was supposed to streamline compulsory licensing. Are you sensing that the Brazils, the Argentinas, Perus, those middle-income countries will use the powers under the TRIPS and compulsory licensing that they have now?
That's a good question. Actually, compulsory licensing is indeed available as a way for a middle-income country, for example, to move and make cheaply its own medicines. But very few countries opt for that mechanism that's available because there are repercussions. We've seen that there are serious repercussions for countries. We encouraged Colombia, we UNAIDS, to use a compulsory license for one of the medicines, antiretrovirals, that is more effective than what they had. And they have. But these others are not able to do because they are afraid of the consequences. So again, it's about governments being in the driving seat. Companies will seek to maximize profits, but governments have to maximize good health. That is their priority, the health of their people, the right health. We're not seeing governments step up in that regard. But let me also add that it's totally unethical for these companies to go and utilize public research in universities that's funded by governments. Many times they will have benefited from the knowledge that is generated by taxpayers' money. And then to go out and do their trials on people in the developing countries and involve them in their research, collect data with them, analyze it with them, use their bodies to test, and then once all that is done, privatize the profits from it and deny them that benefit. So again, we say to the companies, do what's right. Share that technology. It's not yours alone. You got it through rich country taxpayers' money. You got it through trials on people in poor countries. You own it with them. Share it with them. So, yeah, so there's also an ethical issue there.
For sure.
A moral issue.
Peter, any last word from you before we wrap?
Actually, I think one of the biggest challenges in the fight against HIV is the fact that it's no longer top of mind. There was a point when this was one of the biggest things in global health and development, and partly because of the success and the fact that the mortality rate has fallen by 72%, it's no longer a political priority, both at the global scale and indeed in many countries. And that's why we're seeing HIV coming back and increasing in many countries, is because it's kind of dropped off the radar screen. So we hope that with an opportunity to, in a sense, bring a victory against HIV, which, when you think about the scale of death, I mean, this is, COVID was huge. HIV's been bigger. The opportunity to bring this to a close is extraordinary. And I hope that it sort of brings it back up the agenda. It will need money. And I wouldn't be doing my job if I didn't point out that the Global Fund has a replenishment, our 8th replenishment this year. And if we want to be able to fund the kind of scale-up of prevention efforts, and I don't disagree with Winnie that we need to go bigger than 2. We just put 2 as lenacapavir specific. For other people, things like the vaginal ring or oral PrEP, but we need to think big around the scaling up of prevention efforts. And the reality is we can't do that at the expense of supporting people on antiretroviral treatment. we're not going to reduce the numbers of people being provided antiretroviral treatment in order to be able to. So we have to be able to fund a scale-up of prevention efforts on top of supporting people on antiretroviral treatment, and indeed continuing to close the gap and finding the 9 million people who are living with HIV who aren't getting treatment. The two largest funders of HIV programs in low and middle income countries are PEPFAR and the Global Fund, and continued funding of both institutions. And certainly from my perspective, the 8th replenishment, which will be later this year, are going to be crucial to whether or not we can really make the most of this game-changing opportunity.
So, at 3 minutes over time, let me do a wrap and thank both Winnie and Peter. I think the message is clear. We can end AIDS as a public health threat, but it will take investment and it will take scale up. And Peter's right, you can't rob Peter to pay Paul. You can't rob those needing antiretrovirals in order to do the other thing. It has to scale up to end it. It is possible. You know, the excitement in the world when we ended smallpox. We could end HIV, but it will take prioritisation, political will and hard cash, and dealing with the rights and equity issues. Thank you so much for attending, and thank you to those watching online.